So our three speakers are Mike Thompson, Marie Mullholland, and Holly Cairns. And we're going to go over to Mike first, if he's available there. Mike is an abortion provider and he works as a GP. So Mike, you might tell us about your experience providing under the current legislation.
Thanks very much, guys. Yeah, I suppose it's been a privilege and a pleasure, I suppose, to provide a new, much-needed service in the last 2 years or so. I always start this by saying I am pro-life and pro-choice, and that usually upsets everyone. And I think as general practitioners, we do see the full range of it. But yeah, I'm in East Cork, probably only one of the few in East Cork. I'm an open access provider, so that means that my name is public, I suppose, so it's not just our patients who come to it. I'm a GP trainer. I'm on the Train the Trainers group for the ICGP, and also a member of the START group, who are kind of Munster-based collective of GPs and hospital doctors who are trying to, I suppose, get it established and part of mainstream general practice in Ireland. There are new guidelines, actually, which are hot off the press, which are, again, we can distribute what needs to be, if that's okay. So our experience, the good, the bad, and the ugly, I think it's coming from no service. What we're offering, I think, is it's good, it's free, it's safe, it's local, it's anonymous. I think it's patchy. I think it still has to be embedded. I think the hospitals are variable in their level of support, and it's really only a medical service to date. So there are things I think we could work on. There are a few specific things I thought that I might, if it's okay, just to bring up, if that's it. And I was asking, what are the bones of contention, I suppose, that we might have? And if you can, our job always has two pressures, intrinsic and extrinsic. So some of the extrinsic pressures are general practice in itself is just under pressure. There are waiting lists for everything. Same day appointments are a thing of the past. And sometimes termination of pregnancy, it can be very time critical. And sometimes the woman herself has issues about, access and privacy and childcare and travel. So it's hard to juggle that a little bit. COVID has been a challenge, but we've responded to it by introducing telemedicine for at least one of the 2 visits, which is good. There aren't enough providers, GP providers, which is a thing. And I suppose the counselling service, part of my options, if it's needed, and it's often not, needs to be promoted a little bit more. We often divide pregnancies into wanted, which is great, and unwanted, which is fine, and then crisis pregnancies, which tend to take up a lot of our time. So we would rather that my options be used for that middle group, who mostly are probably patients of our own, and probably on average tend to be a continuing pregnancy when you drill down into it. One of the biggest risk factors we find for increasing the numbers of providers are intrinsic factors in the practice. So it just tends to be that a lot of younger, therefore female GPs, are very keen to provide, but they're often in sometimes more vulnerable positions in a practice. There may be an older, male, more conservative principal in the practice who isn't quite keen or is a little bit uncertain, etc., and doesn't want the service to be introduced in the practice. So whilst there are 10 to 15% of GPs registered as contract holders, the true number is lower, and the true number of open access providers, i.e. doctors who'll see anyone from anywhere, is actually quite small. In Cork and Dublin, I think it's very well serviced, but there are still quite a few geographical black spots and outliers, notwithstanding the heroic efforts of some GPs and some hospital posts and stuff like that. The contraception issue, I think when we talk to our UK colleagues, they're less vexed about this. Their issue is if a woman wants to have a termination of pregnancy every month, that's her business, and don't be on about it. I think we're not as good as contraception as we like to think as doctors, but cost is definitely a big issue for that. And the harsh reality is it costs 15 million a year to provide a termination of pregnancy service, and about 120 million a year to provide a national contraception service. So that's the harsh economic reality. There are going to be other pressures on the health service. My main role, I suppose, when I see it, is just to make sure that the service is safe and suitable for the woman. Just to signpost her, make sure it's all okay, certify her. Obviously, there's a few legal things that we need to go through. Give her the medicines and give her the follow-up, I suppose. That's how I would see our main role. the delay, the mandatory delay, we work within the legal framework. It's not great. I don't know if anything mandatory is. There can be a lot of information to impart, and certainly if someone is, and most women are very certain they want to be unpregnant, but some women, sometimes a 3-day delay isn't a curse. It is if it's covert and you're trying to get away from your children, or the spousal violence, or poverty, or stuff like that. It definitely is. But the 3-day delay, we really reared against that in the first thing, and politically it had to happen. But it's probably not the biggest obstacle we've seen. And we were always asking the women that, the first thing before you go any further is you have to wait 3 days now. I don't know, maybe because they feel that they don't, it's very secretive. I think it was another service, like there's no 3-day delay for any other service I offer. I think they've just put up with it, but again, it's something that hopefully can be changed. I don't know if the political will is there. Conscientious objection, as opposed to, I suppose, conscientious obstruction. I think as more and more of our colleagues and our younger GPs get educated and exposed to it and realize that it's actually quite a safe and quite simple physiological thing, and quite rewarding, both for, I suppose, the provider and the service user, I think we're going to get more and more providers. It's going to normalize. And sometimes, that word coercion, sometimes harassing and bullying people, like, why aren't you providing? I don't know. I think there are, some of my very, very best friends who remain my best friends are very vehement that they would never, provide the service. And I think we need to accept that. I think they're quite happy to signpost it. They do so pretty much always to me. It's usually a text or a phone call. I have a woman there for you for that thing, and that's fine. They get my mobile number, and that's it about it. The under 12 weeks thing and the freedom of speech, safe zones. I'm not certain if we would have voted from under 24 weeks as a nation. I don't know where we're at. I don't know if we're that ready for it yet. I think medical management of abortion is it's private, it's remote, it's still grim, still unpleasant. But I think medical management under 12 weeks tucked away in general practice, I think the electors would be quite happy to that. To extend it beyond 12 weeks for Section 12 reasons, I think you will struggle to get providers, and I think you will absolutely struggle to get hospital providers. We're very lucky in CUMH. We have a fantastic TOP service team and 3 or 4 consultant providers, but that even there, it causes intrinsic pressure. There is, beds are resources in hospitals, ultrasounds are resources in hospitals. A lot of the older trained obstetricians would come up with the ethos that the best outcome for a pregnancy is the delivery of a healthy baby with a healthy mother. And you certainly, there's a huge paradigm shift for them, and I don't think you'll ever change that for them. So again, it's how do we attract new consultants without them being, I suppose, ostracized and given. No one wants to be doing surgical terminations all day either. So I don't know how we increase that a little bit. I think it's much easier for general practice. I think we got the easier deal. These are mostly our patients. They're mostly straightforward medically. They're under 12 weeks. And because if there's any complications at all, we have to refer them to our hospital colleagues. What else written down? The safe zones. It's not really an issue in general practice because our waiting rooms are anonymous. There's all life is there, we say. I'm not there at the moment because of COVID, but I don't think there's a few of my colleagues have been picketed and protested at. The vast majority of the patients have run them, and I don't know. I think freedom of speech is important too as well, no matter how offensive it is. And I think that's a minority view, by the way, however, so I'm not representative. Okay, so we have made submissions, I suppose, to the minister as well as part of the START group of how it can be improved. The one thing I would like, I suppose, to push it on, I suppose, is how can we increase GP providers, get a more inclusive 19 hospital service? And the big thing for us, I think, is going to be contraception. How, you know, at the end of the day, women are relieved to be there, but none of them really like being there or want to be there. And to have to go home and have a miscarriage, it's not nice. It's grim at the end of the day. Yeah. So that's our lot.
Okay, thanks for that, Mike. That was lots of information for us to digest. I was just writing a couple of notes down as you were speaking, and you touched on telemedicine and that you can use that for one of your appointments. Would you see that continuing after COVID? Is it something that you would look for or you think could happen?
Yeah, it's I must say, just generally face to face, because we've had with COVID, a lot of virtual experience now, and GPs don't like it. We're a conservative group. We're quite a defensive group, medical legally, but absolutely, the first visit absolutely can be done virtually. I do think for the second visit, blood pressure check, putting a hand on the tummy, I think that's useful still.
Yeah.
But yeah, we have found, I mean, I do think it is. I think the answer to that, I suppose, still would be, I still think it's healthcare. I know there are some who would advocate that, like it reverts back to over the counter in some states, or women on web again, and you don't need to be telling a doctor anything at all. We would think it's still something medical, but yeah, I think we would certainly like one of the visits at least to be face to face.
Yeah, if one can be done virtually, as you say, that could help with a couple of the issues with distance, or you know, some of the more vulnerable groups or people who can't travel as easily. So it'd be great to see that extend. It's something that's come up in our previous events, and it'd be lovely to see it extend. So great, thank you, Mike. We might just move over there to Marie. Marie is a domestic violence worker, and she's just going to talk to us from her perspective about how the legislation may affect people that she works with, and some other issues as well that she's bringing to the table today. So hi, Marie.
Hi, Lucy. Good to see everybody again. Yeah, I mean, obviously the women that we work with are the women who do find it difficult to access services because they're constrained by their domestic circumstances and they're at risk on a day-to-day basis. So Mike refers there to things like, you know, the 12-week limit. That can be very difficult for women because it takes them a while to get themselves into a position where they can actually then start to reach out for the support, the help, the information, the access, and to get enough free space in order to do that. And to actually feel confident enough to do that. The safe zones as well would actually have implications for women escaping domestic violence. Obviously, a lot of the time they're going to be trying to keep the information of what they're doing very much to themselves, and they don't want to be recognised, because then that information can go back to the abuser. And particularly in rural areas in West Cork, where people know everybody knows everybody else, that could present difficulties. I mean, as most people here will know, there are two key times when women who live with domestic abusers are at risk. And one is pregnancy, and the other one is when she attempts to leave. And those are the two most difficult, most challenging, and most dangerous times for her. So all of that in the mix creates quite a whole new range of barriers. So I mean, in some ways, what I wanted to talk about was the need for how, certainly in terms of domestic violence and how we operate, is that it's really important that how this legislation is implemented, it comes from a trauma-informed place, because women with crisis pregnancies, women with unwanted pregnancies, unplanned pregnancies, it's a trauma when they find out they're pregnant. And so how women react and how their thinking and their focus and their needs are all exacerbated within that situation means that it means that we need, in terms of our support services and our provision of services, we need to understand what's happening for them on an emotional and psychological basis. And then that way we can create the kind of service provision and the implementation of the legislation that really meets their need and makes it and keeps it centered onto the service user. Because certainly my experience of dealing with what we always hope is going to be progressive legislation, is that it's the implementation of it that is where it falls down. I mean, you will be aware, I'm sure many of you, that we've had some changes to domestic violence legislation over the last couple of years that all sound great. We have had coercive control recognised in legislation. But I'm here to tell you that how that it actually kind of pans out in reality is very different. I mean, there's very little training in the guards around coercive control. My own service and a number of other services nationally, we have now raised this nationally with the Garda Ombudsman about how women are interviewed. There is a rush to, it's almost like to tick the box and say, oh, we've got a coercive control case in our division, or we're going to take this case. But there's no understanding of the trauma that woman's already in. We've had to pull women out of given statements that were 6 hours long without even a break for a cup of tea. So actually that then becomes as abusive as what she's come from. And so there's no training, there's no resources, there's no supportive structure. So what you see is progressive legislation in its implementation becomes another kind of punitive element of that woman's experience. There's also, I think, too, there's a concern that I would have that that there's a paucity of really meaningful, effective, and responsive supports and services to women, and in terms of that actually are about protecting her rights and protecting her equality and protecting her, just literally protecting her. And I think that what we're seeing is, with what Mike is saying, is there is at the moment, in terms of service providers, there's just not there's not that many coming forward at the moment. So there is a paucity there as well, and it's the same in the domestic violence situation. We have services, but they're not properly resourced. We don't have, I mean, the everlasting kind of issue for us is there's not enough emergency accommodation. We have no refuges. We've got, and are certainly not enough. And this, that's my concern. My concern is that this legislation, although it's certainly progress, that it will founder on the rock of bad implementation. Because if the implementation is based on the least amount of adjustment in the system, to keep that, to keep the status quo as near as possible to what it is, then, and not about centering it on the needs of the women who need the access, then we're going to run into the same problems time and time again. And I think I'd like to reiterate too something that I heard in the first one of these discussions. It was so important that someone said, was that when you make that service and that provision accessible to the women who have the most difficulty accessing it, then actually you've opened it up to everybody. And that should be that, and a trauma-informed focus in how it's delivered, how it's implemented, and how it's resourced as well. So those would be my kind of experiences, I suppose, that I'd like to kind of share with people.
Excellent, great, Marie. It's great to have that insight into how legislation works for the service user. Very interesting. We might pop along to Holly now, unless you have anything else to add, Marie, or?
No, I'm fine. I do want to kind of remind people that we are doing a sexual violence survey, and I might talk about that towards the end, but how important that is, even in light of this as well.
Absolutely. So we're going to speak to Holly about her experiences in the Dáil surrounding the review and legislation in general. So fire away, Holly.
Thank you, Lucy. And first of all, I just want to say thanks to Lucy, not just for organising the meeting, but playing such a big part in Rebels for Choice. Very much brought me into politics, being involved in the West Cork Repeal campaign. So thank you very much, and to all of the West Cork Rebels for Choice.
Happy to be a part of it, yeah.
Yes. So as soon as I got elected, I went about trying to get on there's a cross-party committee We work with the Irish Family Planning Association. So I'm on that. I'm co-chairing with Annie Hoey from the Labour Party and Lorraine Clifford-Lee in Fianna Fáil. So we have regular meetings and with the IFPA, and as I'm sure everybody knows, the legislation will be reviewed before the end of the year. So recently we requested a meeting with the Minister to see how that will play out, kind of the structure of it. So just to update people on that, it was, I think, quite a good positive meeting. We went in with a few different things we wanted certainty on. One of those things was that it would be chaired by an expert in either, women's health, specifically reproductive health, or human rights, one of those kind of things, and that the committee wouldn't be made up of, all the different stances on abortion care in general and whether it should be provided, because this is very much a review of current legislation and not a debate about repealing the 8th again. And it's something that as a committee we're really conscious of, that we don't want to open up that discussion again, so we all try and avoid it if in publicly, on radio, anything like that, that this really is just one of those legislative processes. We need to improve new legislation that has been in operation for a short period of time, and we want that to be just based on the experience of providers like Mike and service users. So there is lots of information being gathered in relation to that, but one of the other things that we wanted clarity from the Minister on is that, when that committee is gathering new data in relation to this from providers, etc., that the people on the committee would actually, have a key role in getting that information and then working with it, rather than maybe the department doing it beforehand and not being, exactly the right information that we're working with. And the Minister assured us that those two things will happen. Amongst other things, but we were delighted with that. So I suppose that's kind of from the cross-party committee point of view, and then for myself as a public representative and for my party spokesperson on this issue, the things that we'll be looking at and things from the abortion rights surveys and the information they gathered in terms of improving the legislation are things around fatal fetal anomalies. So I know that from my experience of knocking on doors, and I think from all of the media coverage throughout the referendum, for a lot of people, it was people who were experiencing fatal fetal anomalies and needed a termination for that reason that really, I think, swung it for them. So just because, Mike, you referenced, is there the public will there for, later than 12 weeks? And it's just my personal opinion, but I think that there is. There's so many situations now where it's a difficult position for medical professionals to be in as well, where they can't necessarily say that it's 100% a fatal fetal anomaly, because that means that the child won't live more than, I think it's 26 days. So if the doctor's not sure that it might live 27 or 1, or then it puts people in a position where they're still forced to travel. And I just think that we absolutely need to change that. And it's difficult because the removal of the word fatal brings up other issues, but ultimately, I suppose what I and my party are working towards is that we have access as early as possible, but as late as necessary. And maybe we don't need to use language around fatal fetal anomalies necessarily, that it's a decision between a woman and her doctor. In addition to that, we would like to see the removal of the 3-day mandatory waiting period. Like you mentioned, Lucy, I think it would be great if that, part of it could be done, as a whatever that is, an online meeting.
Telemedicine, yeah, at the very least. But
yeah, but ideally we'd like to see that removed, because of course there's nothing to stop anybody from going to the doctor and then saying, I want to think about it for 3 days. Like that's absolutely always an option, but we don't think it should be mandatory. So I'd be working to remove that from the legislation also. In relation to access, and we were speaking briefly beforehand, as far as we know, there might be 3 providers in Cork South-West. It is a problem, that there isn't enough people providing the service, essentially. And of course, first of all, my mind went to conscientious objection on that, and could that be changed? But I didn't kind of really realise the legislative barriers around that, you know, and this is probably a terrible example, but the first one that comes to mind is I was thinking, if, for example, your religion doesn't believe in blood transfusions, can you conscientiously object as a doctor from doing that? You know, because I was kind of thinking, and the answer is yes, you can. So it's a whole other ball game to try and actually address that, which I didn't realize. I thought it was just in relation to abortion services. So my own ignorance there. But I think, you know, what we asked of the minister as well is that a lot of the research that the committee do is around why people aren't providing the service, because we know I think it's less than 10% of GPs and only half our hospitals, but we know that the electorate voted overwhelmingly for it. It's unlikely then that the reality is that most GPs don't want to, you know, or don't agree with it. That just doesn't make any sense. So I think we need to talk to, you know, GPs all over the country and find out what it is that the barriers are. And I think Mike probably highlighted something very relevant there. There could be different practitioners in one surgery that, you know, are uncertain about it or whatever, but there must be other things as well. So really important that the committee does work in finding out what that is and provides as much support and, you know, whatever we need to do to encourage more practitioners to provide it. The other thing we'll be focusing on is the safe access zones. Absolutely, and the government had promised legislation on that, and that we brought in before the recess this time, but it wasn't. So we will be following up on that. And I'm just trying to think, is there anything else? Yeah, I'll just leave it there for now, and then if anyone has questions, I'd love to come back in, but they'll be the main things that I'll be focusing on as spokesperson for my party, and then I'll be working with the committee on other things. You know, I don't know if as a committee we necessarily agree on every single one of those specific issues that I'll be working towards, so I'm not speaking for the other committee members, just to clarify when I say that.
Absolutely. One thing I kind of I thought of when you were speaking about the amount of providers, service providers or GPs in the country, was that at the moment it's an opt-in service, and I think we probably spoke about that a lot when the legislation was being drawn up, and that has there been any discussion about like that it could be an opt-out service, so you still provide a space for people to have a conscientious objection, but that's something that they go ahead and do rather than just making everybody out and having to opt in? Is that something you've spoken about at all?
I haven't spoken to somebody about that, and that's a really good suggestion. I think that's something we could look at tabling an amendment into, perhaps. So yeah, thank you for that.
Awesome.
I think that would make sense. Yeah,
brilliant.
I'll have a look at it.
Mike just wants to ask a question there. Mike, go ahead.
I'd be wary about the opt-out, to be honest. But the main thing I was going to say is contraception, Holly. And I know there's stuff happening at the moment, and we have a few people, but any traction there?
Yeah, like it's something that comes up all the time in our meetings, particularly in the cross-party one, that, you know, we really want more, you know, free contraception, more education around it, and, you know, all of our schools from primary and secondary. But it's something that seems to be very slow to get movement on. But I have no doubt that when the review of the legislation comes up, that will kind of spark the public interest again, and hopefully then the political will to act on that, because I totally agree with you, Mike, it's absolutely crucial. We can do so much better.
Yeah. Can I ask you, Mike, what your thoughts on the opt-in, opt-out sort of situation is?
I don't think it'll get a single extra person, and it will antagonize some people, because again, you want to normalize it, and I do think there is going to have to be probably a cohort of GPs who just have to die out, and you have to train up the new people, and you have to make it accessible, and it's the GPs, the black spot of the GPs. If you draw a circle around each non-providing hospital, that's where the black spot GPs are, because how can you provide a service with no backup? We're falling over ourselves in Dublin and Cork, you know, because we have great service. But if you look at you know, I don't want to mention some places, but okay, Sligo, Donegal, you know, I mean, it's not happening, and it's about normalizing it, I think, you know, and it's happening. I mean, all of the GP registrars that are coming through are all really keen to learn it.
Yeah.
But it is going to take maybe 10 years before they're principals in a practice, and who can decide what happens or not. You know, they set quite a good economic fee, which really was, to try and make sure that this wasn't, that if it was displacing other capacity, that at least the principal, you know, felt it right. There was some reward coming in. I think it was increasing, and I think COVID just flatlined it, and I think it'll start to pick up again. I really do.
Okay.
And I definitely think we'll have more than 50% in 10 years. And you actually don't need 50%. I mean, it would be great if every woman could go to their own GP. More and more of us are providing GPs with special interests. You know, we're referring to our colleague down the road for a joint injection or stuff. So every GP doesn't have to do everything. And I think the more you do of something, you get a little bit better at it.
Okay.
So each town should have one, maybe. Yeah.
So it's not unique in that way that people are only referring away for abortion services. They're also doing it for other things within GPs.
Absolutely.
Okay.
And it's a very informal network. Yeah, and more and more, I suppose, you know, with the younger GPs, they're not working full time. They are doing portfolio careers. They're doing 3 days here and a day there. So the idea of your 10 sessions a week, male, pale, stale GP, like, we are dying out. So, you know, it's to really normalize it, and making it othered I can't see, and I would be very much at this side, but I can't see it attracting anyone else into it.
Sure. Okay, Karen, I think you had your hand up there next.
Thanks very much, Lucy, and thanks to the Rebels for hosting these great spaces. I really enjoy them. Okay, I warned Sam about this earlier, but I have a whole list of things that I'm going to ask, and Sam has threatened to bar me from further events if I'm too long-winded. So I'll be really quick, if I can. First of all, I want to say that we're working with researcher Camilla Fitzsimons from Maynooth University, and we've got a survey up and running, and some of the doctors in START have been extremely supportive and helpful to us. So my first question is, Mike, is a favour. If I was to put, or anybody on the call who works with service providers, we're trying to gather as much information as we can from service providers across the country to see what their experiences are with the protesters. So if it's a very short survey, it's about 2 minutes long, and Mike or anybody who works with service providers, if you could send it around for us, we'd be really, really grateful. So that's the first thing. Thanks, Mike. Second thing is, I just wanted to pick up on the point that Marie made about trauma-informed care in relation to the protesters. And what I would say is that it shouldn't be considered trivial, the trauma that is provoked when people have to walk past those protesters. And I think that it really has to be given gravitas, because it is not something just to put up with or to ignore. We are very, very often told in many ways that we have to ignore behavior that upsets us and traumatizes us. But this is very, very serious. And it's obviously, it's women, it's pregnant people, it's vulnerable people, it's also passers-by, and it's people in this country who've been traumatized around the religious orders and their behaviors in other contexts. So there's a whole host of people who are passing by these. They may not even be accessing services, but they are having trauma triggered. And this is a really serious, broad conversation. So when we do this piece, we are addressing that larger piece of trauma, as Marie said. And obviously there is the necessity for anonymity, and it's that anonymity, the right to anonymity, is enshrined in a number of the European and Irish documents that the government have signed up to when we access our healthcare. So it's a very, very serious, broad issue, not just, there is a sense that it is just a small few people, and it's not. It is behavior that is specifically designed to intimidate. And that then is hugely problematic when we have the Minister for Health who's denying that these things are happening, which is why we've got the survey up and running. But he's also saying that the existing legislation is enough to deal with it. And unfortunately, it's not. The Gardaí in Limerick, where we're based, are very clear. They have absolutely no powers whatsoever. So my next thing that I wanted to ask, Holly, if you wouldn't mind, and lovely to see you, just with regard to getting some information, in the last week, we got information from the HSE about Sligo, and we've found out that Sligo only has one GP offering services and only to their own patient list. They're not on the public My Options list, which means that effectively Sligo has no GP, and that Sligo General is only offering abortions on the ground of TFMR and no other grounds. So what we're inferring from this is that obviously up to this point we knew that there was only 10 of the 19 maternity hospitals offering abortion services. We assumed that those 10 were offering full abortion services, and now because of this new information, it's very clear that that is not the case. So what we want to do is we want to try and find out what hospitals are offering what types of abortion. Now, it hurts my soul to talk about types of abortion, because this was a discussion we had in 2018. We were very, very clear that nobody should have to talk about why they wanted these services. But yet here we are in 2021, and I think it's a key issue. There is an absolute lack of understanding across the board that this is happening. People think they can access abortion, and they very, very often can't. So I'm wondering, Holly, you know, with regard to the committee, would that be information that we could get?
Yeah, it's such a low bar. I was about to say, I'm delighted to hear there's somebody providing it in Sligo, even to their own, you know, it's such a low bar, but for a while there was no one in Sligo whatsoever. But yeah, no, it's unbelievable. And it's something we've been trying to look into in general, because in relation to the new National Maternity Hospital and that being on a site owned by a religious order. But basically, so all of that information that you're talking about, you know, the different types of ones carried out in different hospitals, all of that stuff, it's something we've put in as parliamentary questions, but unfortunately due to the HSE hack, we're not getting PQs back from the Department of Health at the moment. But as soon as I get them back, I will absolutely send them on to you, Karen. Yeah, straight away. And we have those questions in, we just don't have replies.
It's great that they're in. I'm delighted to hear that. Thanks, Holly. And if I could have one more thing, and then I promise to stop talking. We're working with the Irish Council for Civil Liberties on wording of the legislation and what that might look like. And the Council of Civil Liberties have said that they would feel that 50 metres would be proportionate and necessary. So we have been pacing out what 50 metres would look like in Limerick and a couple of other sites, and we're really just putting it out there to repealers around the country to let us know. We've set up we're trying to grab data, we've set up a map, we're trying to find out around the country, will 50 metres do it? Is that what we should be pushing for, or do we need to push for 75? Do we need to push for 100? The Irish Council for Civil Liberties say that we have to go for the lowest amount of metres that will get the job done. They've said 50, so we're starting there. But if we get the data that we'll need more, we'll push for more.
And is that from the door of the maternity hospital?
We're hoping that we'll get it from the grounds.
The grounds. Okay.
That's what we're hoping, but again, we're really down to the nitty-gritty of the wording of the legislation now. So would it be the gates? Would it be the grounds? Would it be, you know, and that's where we're at. So we're trying to, there's a load of bits that we're trying to nail down, and one of them is, actually two of them is what you've identified there, which is really important. The wording is everything.
Yeah, I would think, now I'd have to go, as you said, and pace it out, but I would think at CUMH that even if it was from the grounds, that because it's such a huge, like there's such a large road network outside, that you would be passing them on your way in and that would be visible. I would think, but then again.
Okay, thank you for that, it's really helpful.
Unfortunately. Okay, so thanks, Karen. And Karen was one of our speakers at our last event, so thanks very much again for that, Karen, very informative. Maho, I think you have your hand up next. Maho,
Thanks, Emil.
another one of our previous speakers.
I'm not going to turn on my video because I'm on a lounger. So I have one statement, two questions. So one of them is, I really like that what Dr. Mike said, and that's something that I usually say. When we're talking about conscientious objection, one thing is to conscientiously not being able to do it, but refer, for fuck's sake, you know. And I think that's what we expect of any decent human who is not in the business of obstructing access. So I think that's key. And then the two questions that I had, and I think probably Dr. Mike might be able to answer them. And one of them is, number one, in terms of training, is there anything in terms of the curricula or things like that for people who are training in medicine? Like, is providing abortion part of the curricula? And are we ensuring that it's not, like that it's available at least for medical students and, perhaps for, nurse practitioners, look, is there anything that could be done from the educational and training point of view? And the second one is in terms of in practice, how have you been seeing, how the barriers that are perhaps more specific to migrant people, how are they playing out? And two of them that I would be very curious about would be PPS numbers. I'm aware that people need PPS numbers to access the maternity and infant scheme and to access abortion. So it's either whatever choice you want to make, you need PPS for that. And has that come to the service? And the second one is, and I think I spoke to Trish about this a couple of years ago, another GP, and it was the issue of accessing interpreters and how, say, for example, when it comes to services, I know hospitals probably have more access to interpreting services, but how is that playing out in GP practices where if people are under 12 weeks, they should be able to access that as primary healthcare? Thanks, Emma.
That's loads of really great questions. I think Mike might be gone.
He ran away from my questions.
He ran away from your questions. No, he was on call in South Dock. So we were glad he was able to make it.
Doctors going out saving lives.
I know, but maybe we can pass on the questions. I know you did mention at the start that the new GPs being trained and doctors being trained, the younger ones were all very keen to learn the provision of abortion. So I don't know if it's like an extracurricular or if it's on the curriculum or whatever, but it was mentioned that they're keen to learn it, so it must be there somewhere. But yeah, maybe we can pass on the questions for you, Maho. Sorry about that.
Thank you. I'm like won't somebody please think of the immigrants person? Yeah. But yeah, look, I think it's across the board in terms of accessing practically every service. It's becoming an issue, even from the point of asylum, court cases, like everything else. Interpretation seems to be a barrier. All right. Yeah.
And like we said earlier, like Marie was saying earlier, if we make it easier, if we make it tailored,
I think that was me.
It's harder for it. Was it yourself?
Yeah.
I think Marie was saying it as well. Yeah. It's come up a couple of times. If we make it easiest for the most vulnerable, most
and the PPS number, I think, is one that it's definitely, and I always make the case, it is definitely about people who are undocumented or people who are new to the country and perhaps, never needed a PPS number if they never had to work, say they're here as a student or something like that. But we also have to remember that we might also have, for example, returning Irish citizens, as in returning, maybe they were born somewhere else, children of immigrants coming here and then come with, there might be a pregnancy or, that they, whatever choice they want to make, if they don't have a PPS number, that delays access to care. And then also, it's returning immigrants. It's people from Northern Ireland. They don't have a PPS number. So I think ensuring that it's covered is going to ensure better coverage for a range of other people as well.
Yeah, that's a great point. Maybe that's something for you, Holly. Is that?
Yeah, I'm not sure if it's something we could tie into this exact legislation, but certainly something we can look at in general.
Something more to do with the provision rather than the legislation itself.
I'm not, I'll have to look into it. Like, as in, could you tie something into the legislation around not needing a PPS number? I'm not, to be honest, I don't know, but it's something I could look into, definitely.
I think it's across the board, in fairness, like it's, I would love to see a firewall in terms of, okay, if you need a PPS number, that's fine, but make it relatively accessible to access a PPS number and that there is no danger of being deported if you go there, if you present there, because that's the fear. As someone who's
Mhm.
undocumented, who has a reason to ask for a PPS number, they won't necessarily have an issue in getting it, but the fear is that they would come to the attention of the authorities.
course, yeah.
And the way it's presenting in the Department of Social Protection is, if you go, they ask you for what's your reason. So it's identity, proof of address, and reason. And normally when you say, oh, I need it for this, they'll be like, where's the form? Where's the paper? So there is no form to access an abortion. So it's not like a driving license. And it also challenges the thing of like, you have to expose so much private information. It's like, actually, I need to access a termination, or I'm pregnant, and tell that to someone in the Department of Social Protection. You know, so I think that the barrier is much before the health service, but it is something that, I'll stop ranting.
Something to bear in mind. Yeah. Thanks, Maho. Carly?
Hey guys, thanks a million. I wasn't actually going to speak, but I just wanted to kind of add into what Mahu had to say there, just to say that we've got some questions in on that very thing around PPS numbers. So as and when we get a response, we can get back to everybody on that as well, just to add in. But I also had a question for Mike, but I know he's gone, as I said, saving lives, so I can't actually ask that question. But it was really about like open access providers, and I suppose to try to get a sense of like, are they experiencing a bigger increase in terms of people outside of their own catchment areas, I guess, as a result of COVID, and how telemedicine is helping with that, and can we see, you know, how, like, I suppose something call that in. But I suppose it was also just to pick up on a quick point that Marie had made earlier about implementation and just how instrumental it is to everything. But I suppose that, as well as that, I guess from a policy perspective, evaluation is super important too. And I think it's really fantastic to hear a colleague talk about how the committee are, it seems to be very committed to trying to understand you know, how things have been working for not just the providers, but for I don't like that term, service users, but I'm not quite sure what else to say there. But you know, the people who need to access abortion services, how are they finding it? But I suppose what's also important is like, who's collating that information, how is it being framed, will there be recommendations, will they be followed? You know, I guess it's all of those things to kind of add into it. But I guess that's the art of politics there, and you know, I'd be very confident in Holly and her colleagues' ability in being able to play that game as well as possible, you know, to achieve what we need to achieve to get better access for everybody across the country. And just to say also, thanks for the need to put this on, it's been really interesting. Thanks.
No, you're very welcome. Carly, you said you got lots of questions in. Who are you working with? I'm afraid I haven't met you before.
No worries. Yeah, no, I'm actually one of Holly's people. Again, the party I work for, Gary Cannon, like, so he's social protection. So yeah, we had, well, it was me personally.
Carly's
actually.
also a counsellor, so one of our counsellors.
Oh yeah, I forget that. Yeah.
It's a dub. She's a dub, don't say anything.
No, I'm not actually a dub. In your face, Sam Boland. I'm from Cavan originally, so I think that's why I wanted to come to it tonight, because I know actually oftentimes it can be very Dublin centric. I know that, you know, or Cork City centric. Like, you know, like I do totally get that, and you know, Cavan and I'm sure West Cork would be similar in terms of it can be difficult sometimes just even to get to people to talk to them. Never mind, you know, perspectives and politics and all the rest of it. Like,
absolutely,
so really great to see this. Like, and like, you know, I think like everybody else, I was as passionate about trying to get Repeal over the line. So it's I suppose it's concerning me though. Like, there is definitely a feeling of sort of I don't know. I think everyone's still very worn out and burnt out from the last campaign, and it's kind of hard to get people engaged in the review. I suppose that might maybe pick up as and when we kind of get more detail on when that's going to happen and what it's going to look like and stuff. But I guess we keep chopping away in the meantime, don't we?
Yeah.
Thanks.
I think it's an awareness thing as well. I mean, I've spoken to so many of my own friends who who's kind of say, oh, I thought that was all done, you know, and they're still saying that, and I'm like, did not see all the stuff I was sharing on Facebook? You know,
you weren't listening, were you?
You weren't listening to me. Yeah, but we've had plenty of chats recently, so that's fine.
I think, sorry, as well, Lucy, one of the things as well, because like you say, everyone's worn out, and we had a myself and Carly and a few others had a meeting recently with TFMR, and like one of the fears there is that, you know, because obviously so much of the campaign was won by personal stories, and like we always see in Ireland, you know, for real change we have to, you know, make people go out and tell stories, and you know, sometimes suffer a lot of abuse for it, and that like as a priority that we can't let it be the case that people who needed terminations for medical reasons in the past are kind of pushed out in front of the media to tell their harrowing stories again, to just be able to, because they still, like, people who need termination for medical reasons still can't access the service. They're still forced to travel, and during a pandemic,
exactly,
like, you know, something we all need to be aware
that's
of.
come up a few times about how, you know, we want to try to make sure that that doesn't happen again, that women's voices aren't exploited, that we don't have to bare your souls to, you know, to make legislation better when you can clearly see the pitfalls. And that's, I saw Marie had her hand up, and that's something that you said you found in your industry.
I mean, Tara, well, the first meeting Tara Flynn talked about that, it really resonated with me, because I mean, in the domestic violence services, we are deluged weekly with the media. Oh, give us a story. Have you got a woman that will talk to the press? Can you tell us, could you tell us who needs a safe house? You know, why did she need a safe house? Could we talk to her? And we don't do it. We don't, I mean, I think most of the DV services, we don't do it. Women's Aid might occasionally put someone out front, but that's after a long period of that person is like really well able, confident, a long way away from the trauma. But we don't, because we've got to protect those women and their stories. And I think it's appalling that we have to ask women to expose their vulnerabilities in order to what's rightfully theirs, which is their right to protection, equality, and access. And I think we have to stop that. And I think what we need to be saying to the media is, we're not rehashing women's, you're not going to slit their wrists for you so that you can see that their blood is red. What we're going to say is, the data, what we do need is the data. And that's what's really important, what Carly and Karen is saying. I'm a great believer in evaluation. I love evaluations, and I love reviews and consultations and all that kind of thing, because that's where you hear how something is operating, how effectively or not it's operating. And also you get feedback about how to improve things. And we've done that quite a lot in our own service, and we're doing it at the moment with the sexual violence survey. We're asking survivors, if you had the chance, how would you, based on your own experience, what would you like to see in terms of a service? What would you have needed at the point when you needed that service, and what wasn't there, and what worked and what didn't work? So let's ask them, let's collect the data in the same way that we can. I think that's got to be the next focus. It's got to be resourced as well, because let's hear from the service users, from the people who need the access, what it is that they would like to see in terms of that service. Because at the moment we've created a service that the system thinks is the least that the system can do. Let's hear what the people on the ground actually need. And I think that's what I was saying earlier, that legislation, although sometimes progressive in its implementation, is incredibly conservative, because it's about the system having to make the least adjustment possible, not actually putting the woman or the child or the vulnerable person at the center of that service and that legislation. And just, Karen, I want to come back to you on the safe zone. This is an old, I suppose it's an old scar of mine, because you might know that I come from the north. I was on the very first board of the Brook Clinic, the very first Brook Clinic, and I'm talking about the 1980s in Belfast, where we were picketed every single day by Ian Paisley and his Bible thumpers. And it was almost impossible, I mean, for the first year to get anyone to come into that Brook Clinic. And the problem was there was only one access door to it. And as you know, the Brook Clinic was targeted at young people to give them contraception. And they were actually able for a very long time to prevent that service from actually being available in any real way. So that's why I think, for me, safe zones, it triggers me. Yes, you've got to stop, you've got to push them out as far as you possibly can. And it wouldn't be, you know, it might be worth having a talk to some of our sisters and brothers up in the north about that experience of there not being safe zones and how long that has gone on for. And it's also now around like the Family Planning Association has had them for years outside the door as well. So, and the fact that you're even going to look at legislation to make it more difficult could be very, very interesting in terms of an exchange of information, ideas, and experiences.
Thanks, Marie.
Yeah, that's very, geez, Ian Paisley, like, yeah, and as you know, some people have said, oh, you know, rights to protest and freedom of speech, etc. Like, there's places for that, and they're not outside clinics, or, you know, that it is just harassment. But oh yeah, I was going to say that the abortion, it's just speaking about services, surveys. The Abortion Support Network, we're doing one on people's experience of using the provision since it came in, of using the service. And Mara Clark had on Twitter, she had a thread of some of the responses to it, of people who'd had to travel. Sorry, this was surveyed of people who had to travel. So maybe they'd been doing a survey as well of people who'd used the provision. I haven't looked into it, but I'm sure you probably know, Karen, or who else was talking about surveys. I'm sure you're probably familiar with their work anyway. So yeah, I think they were getting some data together, so that should be good. So we're just coming up to 8. Does anybody else have any burning questions? Sam, you have your hand up. Sorry, your hand's the same color as the background, so I couldn't see it.
Yeah, I actually have two things. First is, Karen, I know you've probably sent me that survey before, but if yourself and Marie want to send me on details of both those surveys, I'll throw them up in links on the social media we're doing in association with the event. And secondly, it was a question for my friend from Cavan. On the subject of safe access zones, I know that in London, the case is of Ealing, where the local council enacted a safe access zones in Ealing. So I was just wondering whether at a council level, where, you know, we've spoken to Holly about what's happening at a Dáil level, but at a council level, you know, is there any discussion, or is there any appetite for discussion about sort of localized safe access zones?
I can take that very quickly, because we've been working a lot on that. The local councils have almost unanimously said that they will not deal with that and don't have the provision to do that kind of work. So there was a couple of test motions put into some of the councils of the country. I think Sligo, maybe a year ago or maybe 6 months ago, their legal department came back and said at that time, absolutely under no circumstances. And then all of the council execs in the rest of the country followed suit very quickly. So our initial stance was to get legal advice from the brilliant Mairead Enright, and she said to us at the very start of it, she said there's no point going the local council route. You have to go straight for legislation. So that's why we took that route.
Yeah, just to back that up, like, I mean, I was only elected back in 2019, so it was a year after, and about 6 months after, I suppose, the legislation that a lot of the councils had already at that point. Councillors, I guess, pro-choice councillors had already tried to do a lot of a motion that passed in my own council in South Dublin, for example, and lots around the country. Essentially, as councillors, we have very little powers at all to do anything much, other than at the moment the disposal of public land to private developers, and even that's been taken out of this now under the new act. So, like, yeah, I mean, I think largely that we would have actually gotten support, probably in the bulk of councils, not maybe all of them, but like I think the bulk of councils would have supported, or councillors would have supported pro-choice councillors in that respect. But it just isn't a possibility, unfortunately, much as I would have liked it to have been. But not for want of trying, as Karen has pointed out.
Yeah. Could I be very cheeky, Carly, as I have you here? We in Limerick Council, we got through, in the last full council, we got through a motion getting unanimous support from all the councillors that they were going to write to Stephen Donnelly and ask for the safe access zones. Now, obviously, it's only an exercise in optics, But our next step from September is to try and contact as many local councillors or councillors as we can to get them to do an exercise in optics, because we feel that it'll be good coming into the review time in the autumn. Just it'll be a good way to bring attention to the issue. So we have the wording that we got through, and if it's something that you would be interested in working on, we would really love that if you'd like to.
Yeah, absolutely. No, it sounds really good, Karen. Send it on to me. I suppose just to kind of just throw it out there, local authorities across the country are all ad hoc and act really differently, and some people can get a motion through pretty quickly, whereas my motion, the last one I just got in, was about getting like repair cafes in and a library of things into our council. It was on the list for about 8 months before it actually got heard. So
look, I know,
yeah, definitely do, and I think like
target the councillors outside of Dublin, and
yeah,
more likely to get them.
It's quite likely, but like it's still no harm in putting. We could put questions down if they get at least an answer or whatever, you know, or well, possibly not on safe access because it's not quite, you know, out around the council. But like definitely, I think like the more pressure we can put from as many different areas as possible, I think is good. Yeah, sure. Thanks.
Thanks so much,
Yeah,
Karen.
and give us a shout if we can help with that, Karen, if we can feel out some of the councillors in our areas. I know there's people who stand out that will do that.
I will absolutely take you up on that.
Do
Thank you
reach
so
out
much.
to us on that. And I just have a bit of housekeeping to do and say that there is a stall going to be run by Rebels for Choice in Cork. Is it Daunt Square, Sam, or somewhere, Patrick Street?
Outside what used to be Brown Thomas's, our usual spot, but we haven't done one for a while, so we have to sort of scout the lay of the land. So it'll be somewhere in Cork.
Yeah, but that will be possibly 31st of July, and keep an eye on social media and share it and all that kind of stuff, and talking to people about all the great stuff we've been talking about in these events. We can start to talk about them far away but face to face.
Oh, I love me a
Shout
good
at each
stall.
other.
Stalls are great.
Yeah, okay. The return of the stall. Yeah. So I think we'll just start to wrap up there. Thank you so much to our lovely speakers for coming. Unfortunately, I can't say thanks to Mike, but I'm sure Sam will pass on the message. And thanks so much for coming. And it's great to see all your lovely faces again, and everyone who joined in.